slightly lower than the fresh embryos. The main advantage is that you don't need to undergo an ovulation induction yourself or for the donor again and again. And usually one cycle should be enough to produce a healthy pregnancy if good number of embryos can be frozen. The good thing is that studies have shown that there is no risk of increased congenital anomalies following the use of frozen thawed embryos. Now what happens if there is azoospermia? Azoospermia is absent sperm count in the ejaculate or the semen. Now it does not necessarily mean that the person is sterile. This means that the sperm production might be taking place, but it is not coming from the testis to the ejaculate. In this kind of a condition, what a urologist can do is to aspirate the sperm from the testis by doing a testicular biopsy or by doing a percutaneous epididymal sperm aspiration. The sperm aspiration may be carried out on the day of the oocyte retrieval or prior to the IVF cycle. Assisted hatching is another procedure that is related to IVF and is now commonly done across the world. Earlier people were baffled that they were finding good quality embryos, transferring them into women with good endometrium, but there was no pregnancy. Then a reason was thought that it might be because the embryos are not hatching. So for this, assisted hatching is used. It can be done for women usually over 35 years of age or who have had repeated failures or unsuccessful transfers. Now hatching is done by two ways. One is a chemical hatching and the other is a laser hatching. As you can see in this image here, from one side the embryo is gently sucked and held in position, and the laser is passed. Usually at least 3 times it is fired to create a small hole in the zona pellucida. Blastocyst culture. The blastocyst stage of embryonic development usually occurs just prior to implantation, which may be day 5 or day 6. It is an embryo made up of 80 to 100 cells and reaches this stage 5 to 6 days after fertilization. However, on day 2 or on day 3, the embryo needs to be transferred to a special blastocyst medium for further growth to take place, because additional requirements are there for the embryo at that time. The advantage of the blastocyst transfer is that it allows for you to select, or the embryologist to select, the best quality embryo and then transfer it. It also helps in reduction of twins and triplets. The disadvantage is that monozygotic twinning can occur. The chances are less, but it can occur. Pre-implantation genetic diagnosis has turned out to be a big boon for couples who are at a risk of having a child born with a genetic or chromosomal disorder. The only options earlier were chorionic villus sampling or amniocentesis. These are invasive and not the first choice anymore, because if the patients can afford it, they get to know before the embryo transfer that the embryo is going to be having some abnormality, so the embryo is not transferred. Earlier, the only option was, when this kind of a condition was detected at 17-18 weeks of pregnancy, to do a therapeutic abortion, but this is not required anymore. So how does it work, PIGD? A single blastomere is removed from the embryo and tested prior to transfer. Commonly the chromosomal abnormalities, trisomy 13, 18 and 21 are diagnosed. A lot of common genetic disorders can also be tested. But nowadays this is a specialty, and with a lot of genetic labs developing newer probes all the time, even the rarest of conditions can now be diagnosed. Oocyte freezing or egg freezing is another emerging technology. The oocyte is more sensitive to cryopreservation than the embryo because of the higher water content in the egg, which predisposes it to ice crystal formation and subsequent damage. Now, who does it benefit? Egg freezing. Women undergoing cancer treatment to preserve their fertility, for younger women who are career minded and want to preserve their fertility for the future. Couples undergoing IVF sometimes prefer to freeze egg instead of embryos once their family is completed, as it would be emotionally easier to discard frozen eggs instead of embryos. Now we come to oocyte scoring and embryo grading. Now oocyte or the egg the factors that are included in the evaluation by an embryologist are the cytoplasmic dysmorphisms, extracytoplasmic dysmorphisms, and the oocyte corona cumulus complex. So as you can see, this is the signs of a mature oocyte. The cumulus cells are dense, and the polar body is in place, and the zona is not too thick and not too large. So how do you assess fertilization after insemination? It is pretty straightforward really, as a fertilized oocyte should have 2 pronuclei and 2 polar bodies. As you can see in this image, the 2 pronuclei and the 2 polar bodies in place. As the embryo grows to day 2 or day 3, grading becomes a little more technical. So the embryos are routinely graded on cleavage stage as, or day 2 or day 3 as A, B, C and D. An A embryo is usually a top quality embryo. A B grade embryo is a good quality embryo, but not suitable for selective single embryo transfer. A grade C embryo is an impaired embryo quality, and grade D embryo is a really bad quality embryo which you ideally should not be transferred, because even if it results in a pregnancy, there is a chance of miscarriage, increased chance of miscarriage with a grade D embryo. Why is this important? Evaluation of the embryo quality is of prime importance if you have to have a successful IVF or a surrogacy program. Usually what we look for is cell numbers, fragmentation, blastomere sizes, cytoplasmic anomalies and compaction. Cleavage stage embryos range from the 2-cell stage on day 1 to the compacted morula composed of 8 to 16 cells on day 3 and day 4. The number of blastomeres on day 2 or day 3 is used as a primary criteria for embryo assessment, meaning that on day 2 at least 4 good blastomeres should be seen, 4 equal sized blastomeres should be seen. The A quality embryos or the best quality embryos must exhibit